So have mercy on my soul. All right. No, not someone else. This is artificial intelligence. So let me get you guys off the screen here so I can do this. And okay. And again, this is Clozapine Light. All right. And the Laitman approach, that's not me either. So if it sounds megalomaniacal, this is, I know it has to be revised and all the rest. Okay. So over the next 30 minutes or so, I'm going to try to give you an approach that I think is fundamentally different than what is basically out there and what people are proposing. And I've really developed this approach with my wife in partnership, Team Daniel, and we're really getting it operationalized with Dora Mind. And what it really represents is a shift, and it's got three core ideas. One, as I keep emphasizing to you all, family-centered treatment. Two, obviously, optimization of clozapine as a platform for recovery. And three, a commitment to meaningful recovery, not just symptom suppression, but true return to life goals. That's the three cardinal things that you really, really have to understand. And I think that's a fundamental change from what most people consider when they're dealing with people with persistent psychotic disorders, especially schizophrenia. Oh, shit.
But we just reported that.
Oh, well, the question is, how do I get it to? I have it shared and I'm trying to get the next slide. This is, oh, maybe I can do up here. Let's see. The question is, can I do, oh, geez, that was way too far. Hold it, that'll work. Okay. All right. Slide two. This is going to be a bitch. Sorry, because I have to, my little clicker switch doesn't work. And this is a part of it. I don't want you to grieve your children. And we were told this also. What's the message you get? The message we got was lower your expectations. Your child is going to have a very different life.
Recording in
Don't
progress.
let them, don't worry, we'll be lucky. We'll get them through high school. Don't think about college. But what I want you to do is, and I think, it's okay. You can grieve a little bit because this is hard, but don't stop there. What I want you to realize is that there is a treatment approach that gives your kid a real chance. And that's what we want to talk about. We've come up with a decent protocol and we're trying to get it out there and make it generalizable. So let me see, please. Ah, there it works now. So again, where do we start? We start with Daniel. The reason why I'm doing this is Daniel. And really, I wouldn't be doing this. I was a nephrologist before all this. And, first episode was 20 years ago. He was quite ill. He was only 15. We started clozapine after failing several antipsychotics. We were cycled through three at one time at the worst. And he had a dramatic remission within months. And it's been a continual process where even to this day, he's showing improvement. We started Team Daniel. Again, I didn't make these slides, and that was a big push. We got onto Facebook. We published the book. And with all this, we started to get meaningfully involved with the community. And as for Daniel, I full recovery is an exaggeration, but I can't edit these slides worth a damn. He's made a dramatic good recovery. College, marriage, really being integrated into the psychiatric community, doing stand-up comedy, living independently, really, really being a mensch, a good person. And what more could you want? He's a kind soul and he has purpose and meaning. And that's what it's all about. Who am I? Again, I didn't make these slides. Um, who am I? I'm a nephrologist. And basically, I became aware of clozapine because I met really brilliant people, especially Deborah Levy up at Harvard, and Michael Muffson is still practicing up at Brooklyn and is affiliated with Harvard. Brookline. And basically, they told us that our son had resistance form of psychosis and he needed to be on clozapine. And eventually, we took over his care because we wanted to make sure that it was optimally used because we found that people weren't addressing side effects and we didn't understand why they were not because the side effects were predictable and treatable. So by 2012 or so, I had 10 or so patients. Um, and then over the last 15 years, that's burgeoned so that I've had treated over 200, more like 300 patients over 30 states. And we employ not only clozapine, but really an approach that we take, a very holistic approach. And we found that there are cross-tapering protocols that work, slow titration, side effect prevention, and we keep going. I've taken the fact that I came from a medicine background and used that because when I was a nephrologist, I'd always be treating side effects of the medicines or side effects of the illness. And I brought medicine into the realm of psychiatry. And and I think being a nephrologist and coming at it from the outside has been distinctly useful in this entire journey. But as you say, when you go to your treating psychiatrist, they go, "Why do you want to listen to this nephrologist?" So, why
Uh,
do you? Guys, please mute. Um, so it has a real reputation problem, clozapine. You notice the small guy with the beard. I guess that's me now in the picture, as opposed to the tall guy, because I'm not very tall and I'm definitely very gray. Again, it's always been reserved to being the drug of last resort. And that just doesn't make sense to me. We know that if you treat clozapine with clozapine earlier, the recovery is more robust. There's a large literature that suggests the longer you wait, the less robust will be the recovery. Now, on the 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 unfortunate part is that this literature is very short term. Our experience is, and I don't want you guys to write your kids off if it's been 8, 10 years before you get to clozapine, but I do want you to be aware that it's going to take longer and it's going to take more work to get your kid better. So the traditional view is try one, try another. And the teaching and what's out there is after two failures, you should start clozapine. But of these clearly resistant people in the United States, only 5% or so of those people that have shown absolute resistance to all other antipsychotics are on clozapine, whereas 30 to 40% of those kids are on multiple antipsychotics. And that's just bad medicine. I say when you go and you have your kid, you should be considering clozapine right from the get-go. You're not going to get anyone to do that except for me. So accept a trial, and I don't think this is wrong because we don't have the data to suggest that clozapine has to be the very first drug. There is probably a subpopulation. I don't necessarily believe this, but there probably is something, a subpopulation that might do okay with another antipsychotic that's easier to manage. I personally believe that if you start clozapine early, you're going to be using less of it. You're going to affect the best outcomes, but at least be considering it. And certainly the data is incredibly strong that if you fail one antipsychotic at what's considered therapeutic doses for over 4 weeks, you need to move to clozapine. And you need to move to someone that is willing to do clozapine expertly because clozapine is not an easy drug. It has to be managed expertly. So we want to change this from what is the standard of care, which is this is good enough. He's not in the hospital. He's living in your basement, but he's not trying to kill you or he's not trying to kill himself. Maybe. By the way, clozapine reduces suicide risk by about 90% compared to the other antipsychotics. So that's often also ignored. And we've seen multiple suicide attempts, and we've unfortunately heard of multiple completed suicides where they've never had the opportunity to be on clozapine. Our belief is good enough is not living in your basement playing video games, but returning and having a life. School, work, sustained relationships. Like turn the page. This is the model. And again, you need all of it because clozapine's, again, I always say this, it's not magic. We don't have a magic bullet. All these illnesses are complex neurologic diseases. Often, as I said, they're mostly neurodevelopmental. We're not going to fix everything. Your kid, if he has schizophrenia, is still going to have schizophrenia. You hear Bethany say, I've made a complete recovery. No one makes a complete recovery. Neurodevelopmental, they're neurologic diseases. There's always something. Bethany's made an amazing recovery. She, for all intents and purposes, was brilliant and is brilliant again. But no one makes a complete recovery. I think that's a false leader. And part of the problem with psychiatry is they're always trying to get rid of every symptom. And that's just the wrong approach. So you start with biology, you start with clozapine optimization. Once they're in and they are well enough that they are aware that they may have a problem, you start to bring in the psychosocial therapies. And that includes cognitive behavioral therapy, psychosis of form, dialectic behavioral therapy, especially if there's emotional dysregulation. And really importantly, because when you're dealing with psychosis and psychotic disorders, it's not only the positive symptoms and the hallucinations and the delusions, it's the cognitive issues. It's the negative symptoms. It's things like the inability to get started, the emotional flattening, again, the slow processing speed on the cognitive side, the inability to have attention and working memory. You can work on these skills. And then you have to put the social supports because guess what, guys? Your kids are going to need support one way or another. Daniel to this day needs support. And, God help us, I think, I'll take it. And, when we're gone, I believe I'm lucky that and Daniel's lucky that we have other family members that will help him and that he's married as well. Family, you're not bystanders. And this is part of what we're describing here. You are partners in this. You guys are there all the time. I see your kid a half hour once a month. You have to be partners. And then if we do all those components, again, community engagement, getting rid of isolation, returning them to a life of purpose and meaning. These are the pillars. Ready? Again, these are non-negotiable. Clozapine management, safe titration. And what do I mean by that? I mean by starting slower than what's in the PDR. We're talking about 12.5 milligrams at bed and then only going up 12.5 milligrams twice a week. It is so much slower, but what we've seen is that we've had zero incidents of any serious side effects, like the agranulocytosis, the very low white count that you can see and that people are terrified of. We've never seen myocarditis, and the part of the reason is the slow titration. If there's any one feature that's really central to our regimen. It is this slow titration. And again, that also allows you to be proactive and manage side effects effectively. And then we have family support. We really partner. LEAP is one of our methods, but it's not only that, it's the education, knowing what you're dealing with, because people are not told. People, you always get this diagnosis, psychosis, NOS. Is it schizophrenia? Is this autism? Is schizoaffective, bipolar? Don't worry about the diagnosis. Worry about the process. This is a psychotic illness. People will blame it on, Lyme disease, or they'll blame it all on pot, or they'll blame it all on, they got a bad cold, pandas. If they have a persistent psychotic disorder, it needs to be treated. And you got to understand that. and you have to provide the support. And we always talk about education, 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 but then learning to be optimistic, learning to have reflective listening, talking to your kid, and working on the relationship. Because if you work on the relationship with your child and you work on your relationship with your doctor, that therapeutic relationship will build an alliance which will allow you to do the hard work of the expert clozapine management and will allow you to support your kids so they can start doing the psychosocial therapies. And these are really not elective. These are core elements. And then we add on the person-centered integrated care where people talk about diet and exercise. Everyone has to do these things: diet, exercise, sleep hygiene, housing, peer support, community engagement, substance use intervention. All of these are really important because when you talk about substance abuse, almost 85% of all people with psychosis, if you're going to include cigarettes and alcohol, use a substance. And then what's also really a pillar, five pillar, whatever, is that we follow you and we continue to follow you because these are long-term processes. So again, as I said, the slow titration, that is really part of a signature part of our protocol. And again, 12.5 milligrams. I'm going to emphasize that at a start, and 12.5 twice a week. Now, if you're of Southeast Asian descent and a woman and a non-smoker, I'll even start at 6.25 because you'll have a slower metabolism. And given that metabolism's different, I will start monitoring levels just to see where you're at. Now, this is where the myogene test would be somewhat useful because it'll tell you their how they metabolize the drug, and I think it's worth doing. But the bottom line here is you start low and you go slow, and you target the timing you reach 350, 900 nanograms or higher. And as they improve and their positive symptoms abate, you go from a twice a day regimen or even 3 times a day regimen to shifting it slowly over to the bedtime dosing to minimize the daytime sedation. And why you go slowly? Again, it really reduces the risks, near minimal to myocarditis, the low white count, seizures, the fast heart rate, because the sedation, the constipation, and the weight gain, because it allows you to add what you need to add so those things don't happen, because these are all predictable. And that's what brings us to the side effect management. Again, you do your metabolic, when you're doing your blood work, we metabolically screen every month or so, which is probably a little excessive, but you should do a hemoglobin A1C every 3 months because glucose intolerance is predictable if you don't do what you're supposed to. And that means start the dietary counseling, start the exercise regimen, start the metformin right away, and really consider early use of GLP-1s. Cardiac concern, again, slow titration. Check the HSCRP. If it's elevated and the person's tachycardic early, do a tropan and slow the titration all the way down. I've never had to do that with any of my patients going this slowly, but that is still a reasonable thing. But control the heart rate. The fast heart rate in and of itself will increase anxiety. So control that heart rate. Add the beta blocker early. If they are having problems with low blood pressure, which is a side effect of clozapine because it blocks the adrenergic tone that controls, squeezes the blood vessels so that you maintain blood pressure, slow the titration down even more. And you can add things that will increase blood volume, something like fludrocortisone, which is something that we use regularly. You do the hematologic workup, even though REMS no longer exist, but you don't be a slave to it. Again, what is the incidence of agranulocytosis, the severe low white count of less than 500? In the best of hands, it's somewhat less of 0.2%. So 99.8% of our kids will not get this. I think it's closer to 100% than that even. So if the kid misses a blood draw, make sure that they stay on the clozapine. Please try to do the first 18 weeks because that is about 80 to 90% of the risk, but do not let them come off the clozapine for that. And we now write clozapine monthly at a time, and I always give a little extra. And there are refills. So it's treated like any other medicine. Neurologic side effects, again, if I'm suspicious that they're going to be going up to higher levels, I will start lamotrigine early. I don't let them have seizures. It's not a good look, uncontrolled seizures. I did happen to have some of those happen early on. I have to admit, a subdural hematoma. I've had a broken collarbone. I learned my lessons. This is 15 years of doing this on a very large scale. And then, as we've talked about, gastrointestinal side effects. Clozapine slows your bowels down. It's predictable. Treat it. Start the laxative. Start the osmotic, laxative stool softeners. Make sure there's adequate hydration. A fiber-rich diet, but never give a fiber supplement. Metamucil is a contraindication. It actually turns into concrete in your gut. And please be ready to address the excessive salivation at night. There are topical agents you can use, and there are oral meds that you can use, but you should always start with topical. So it's great that Ann and I can do it. What's been the big message? Well, the message was 3 years ago, two very motivated non-physicians came to me, but they had loved ones that had psychosis, and one of which family member was already on clozapine, and they searched the literature for who had the best outcomes, and they found us. And that was 3 years ago, and Doramind launched 2 years ago. And it's a way of scaling what I do. And God knows what slide this is, but it is, there we go. What they really focus on, and this was critical to me if we're going to do this, because they wanted to take my approach and make it more generalized. You have to only focus on psychotic illnesses, period. And you had to focus on clozapine. That ultimately, now we don't start everyone on clozapine at the very beginning. There are some kids that start on an LAI, but we're always looking to add clozapine to the regimen, always. And that is what we do. And it is continuous care wherever you're at. And what is really kind of neat about this is in the beginning, when they're intensively managed, you'll meet with one of my NPs up to twice a week, maybe more. And it's a real partnership, and that's enabled by the tech. There's the Doramind app where you can text in and you'll get treatment. You'll get results. Now, one of these slides says it's 24/7. That's a lie. Nothing is 24/7, but it's close and it's data driven. We try to really check levels. We are checking outcomes. And what is really cool, I want to report now after 2 years of doing this is the results that I got were getting with the NPs doing this. So it works. And as I said, the intensity changes. So first tier, which is unfortunately more expensive, and we are working to make this the next 2 years of the Doramind life. Our big goal is now to show that it can be cost effective and we can bring it to the masses. So we're trying to do something that makes it cost effective for everyone else. So the stability tier is when we're really starting your kids out. We're really doing a lot of intervention and we're there a lot. And often I'm very, very, very involved in this part. As time goes on, I've been working with one of my NPs now for 3 years because she did her clerkship with me. I'm less involved as time goes on because I really one on one person. And the whole idea is for them to do more and more. And that usually gets us into the alliance tier. And that's really working on the therapeutic alliance, continuing optimizing psychosocial therapy. And that can be anywhere from 6 months as a guesstimate to really 18 months. And then finally recovery. And then you basically are on autopilot. I have a whole group of people, and we're starting to see some of our kids that are going to 8, 12 weeks. And that's really the recovery. That's where, they're basically back into their communities. And that's the goal. Less medical care, but we're still there. We're still in the background, but doing more and more. Again, normalizing and demedicalizing, but knowing that you're still there. And why you're still there is because we have the family. And that's what really counts. And you're the unit, boy. You're the one that's really going to determine how your kid does. I know it's a lot of pressure, but that's the reality. So again, we educate. You got to understand what psychosis is. It is the detachment of from reality that brings suffering or decline in your social functioning. And we want to get you on, all of you on, the one path to recovery. We got to communicate. You got to be open. Open dialogue is this thing that came from Finland. And we try to do that approach. We try to meet you where you're at. We'll bring the families in together. You're really integral in this whole thing. And we try to partner with you guys. I really, part of this whole thing is being family involvement. And we support you as much as we support the kids. Because again, a lot of you guys have learned helplessness and learned hopelessness. And we try to really celebrate every win. And believe me, there are lots of wins. And again, what's the real world impact? Well, this is the data that we have, and this is why Doramind originally came to us. So in New York State, where I gave the OMH talk, we've seen the use at Office of Mental Health sites go, and I'm not solely responsible for this, obviously. I would like to take credit, but that would be, really a little too self-aggrandizing, but it has gone up from 2.8% when we started this approach. And it was really over a 15-year time span, but recently it's picked up that it's over 20% now. Ann and I have treated well over 200 patients. And what we've noticed is an 80 some percent decrease in hospitalization, which is the same as what Doramind is getting. Decrease disability days, return to work to school, improve family relationships. In fact, after this, I'm getting dressed in my suit and I'm going to another wedding of one of my kids. And really just a tremendous improvement in quality of life, a real life. And that's the recovery. Whereas in the literature, the meaningful recovery rate hovers around 14 or so percent. We're at 70% or so. So it is really impactful. And that's what I want you to take away from this, that we can make a difference. And that's changing the narrative. And that's the paradigm shift. I like that. That's nice, the top of the mountain. Um, and again, lower your expectation, long-term residential, limited work, harm reduction, all well and good, but really breeds pessimism and low expectation and really, in my mind, depression. You know, uh, you, Ann's big thing was Daniel was not going to be homeless. I wanted much more, and Ann did too, of course.
As a
Um,
start.
it was a start, but it's only a start. Recovery and remissions, I'm telling you, because I've seen it now for the last 15 years, are possible. You got to just keep working at it and be proactive. Try to get them back to school, work, relationships, and again, celebrate whatever their meaningful life goals are. Not everyone's going to return to work. They may not all make money, but you can profoundly influence them and profoundly improve their lives. And you just have to keep at it. You really do. So again, core principles, again, to repeat, early clozapine. So that's the E of our E's protocol. assertive management, which includes the slow titration, the therapeutic drug monitoring, and that's also S because it's slow process. And again, proactive management of the side effects. And E, the engagement. The last really important thing, family involvement, making sure that you have done all the things that you can, including the recovery-based approaches, the psychotherapies, the cognitive enhancement therapy. And what's our goal? Meaningful recovery. Again, a life of purpose and meaning. Still a lot of challenges out there. Again, clozapine, that stigma does still exist. And there's a lot of geographic barriers, and we are still struggling with the reimbursement issue. And the really big thing is the training gap. So, and there's a lot of fragmentation. A lot of psychiatrists will not do the medicine that needs to be done. So, what do we say? We can do better. Let's make this standard of care. Let's educate and train these people. There really is a correct way of doing this. All I'm saying is use the most effective medicine in the most effective way and use the other approaches that we've also found to be so effective. Put them together. Stop being so nihilistic. People can get better. We need policy and advocacy, guys. This is also where the families come in. We really got to go to our people that do the laws. We need people to understand HIPAA better so they communicate better with you. We need better AOTs, court mandated treatment laws. We need to integrate our technologies so that we can get all this into a large system so that there's more data, because the more data we have, the more people will be convinced and the more education and training that we'll have. And then we can disseminate this knowledge. And this is many years. This is not going to be overnight. I wish it was. Been at it for 18 years and we're moving, but we're not there yet. So what are the takeaways? Again, you're it's treatment resistant psychosis or schizophrenia. It's not a diagnosis. I like this. It's an opportunity. I thought that was a very clever thing from AI. It's the first antipsychotic fails, or I would always say, always consider clozapine even at the beginning, but I'm being realistic. Always be thinking about it. And if you're at 4 weeks, 6 weeks with a therapeutic dose, it's time for clozapine if your kid has not recovered sufficiently. Go slow. These things take time and manage side effects. Be willing to monitor, insist that your kid gets seen, and really, really be on top of all of the stuff when you're talking about clozapine, because it needs to be done expertly. For the families, again, if one antipsychotic has failed, ask about clozapine, find a provider, again, that will do this. Remember, this is for you guys, families. Recovery is possible. You got a partner. And again, return your kid to your life goals. So, a future of meaningful recovery. Again, early intervention. Psychosis is optimized, not just managed. Again, being able to manage the symptoms. You don't have to try to get rid of the voices. They just need to be manageable. What you're really striving for is function. And remember, families are partners. And again, where hope replaces hopelessness. So again, this last slide, we return. Don't grieve your children. Make them better. And again, you know, you're going to grieve a little bit because I have to be fair. This is hard. Um, and but it's don't stop at grief. That's what I'm asking you to do. Don't accept a poor outcome or inevitable because they're not. Don't settle for managing when recovery is possible. Keep pushing, even in your kids where the clozapine shows resistance. There are other steps along the way. Don't forget about these other modalities. There's electroconvulsive therapy is very effective with clozapine. There are ways out of this, and be persistent. Do not give up on your kid. Do not give up on clozapine. One of the mistakes I've seen made is that people say, "Oh, clozapine doesn't work," and they stop it. Oh, and they stop it. Sorry. So again, this is a different way of treating psychosis. It's evidence-based, it's systematic, it's monitored, it's family-centered, and it's effective. You deserve this standard of care. For clinicians, consider how you can bring expertise, hope, and optimization to your patients with psychosis. The future of meaningful recovery starts with embracing that simple, powerful message. Don't grieve your children, make them better. Thank you. Okay, that was rough.